2022. We did a CT abdomen pelvis with contrast, and it showed a cirrhotic liver morphology with sequela of portal hypertension, including gastric splenic varices and a large volume abdominopelvic ascites. It also showed a loculated cystic lesion measuring 3.6 centimeters in the lower left quadrant, extending into the pelvis. It abutted the sigmoid colon and posterior aspect of the urinary bladder. And then he also had cholelithiasis.
All right, amazing, Kevin. Thank you so much. Just to make sure that we got this right, it sounds like there was, on the imaging itself, there was stigmata of portal hypertension and then a cystic mass in the lower left quadrant.
Yeah, that's correct.
All right. So, acknowledging that we are just starting to record now. So for those of you who are tuning into this on YouTube, I'm going to give out just a brief summary about where we're at so far in the case. And then we'll sort of pick up the features that we have here in terms of how the labs help us, and then I'll leave the imaging for you to walk us through, Sharmiz. But so far where we are in the case is it's an elderly gentleman with a subacute course of abdominal pain and abdominal distension. We know that this gentleman has a background history of alcohol use disorder, and on exam we see features suggestive of cirrhosis, but we don't necessarily see on exam we see features suggestive of ascites, but we don't necessarily see the other stigmata of cirrhosis. So we're primarily dealing with what seems to be ascites on exam, and then these very interesting lab and imaging findings that we have here. So in terms of how the labs help us, again, we continue to make a case here that we may not necessarily be dealing with cirrhosis-mediated ascites. And what features of the labs tell us this? Well, first off, we see a relatively normal platelet count of 362. One of the most early laboratory findings that you can see in someone who has cirrhosis is actually thrombocytopenia. And there's two mechanisms by which that happens. The first is that mechanism of hepatic dysfunction that we mentioned before, right? Cirrhosis equals portal hypertension plus hepatic dysfunction plus hyperestrogenism. In the hepatic dysfunction category, the liver is responsible for at least contributing to platelet production by making TPO or thrombopoietin. In someone who has cirrhosis, the liver is oftentimes dysfunctional, and so they may have low amounts of TPO. But then the other piece of this is the portal hypertension. Portal hypertension backs up along the way and causes splenomegaly, which can also cause platelet sequestration. So in this case here, the absence of thrombocytopenia decreases the likelihood even more that cirrhosis is likely at play here. You may say, but wait a second, the liver enzymes are normal. Doesn't that mean that this patient's liver is normal? And actually, long-standing cirrhosis oftentimes leads to, patients will oftentimes have normal liver enzymes. The AST and ALT can oftentimes be normal. So those aren't necessarily helpful for us here in the same way. But the other lab finding that's particularly helpful in, again, making a case against cirrhosis here is the relatively normal INR. Because again, the hepatic dysfunction also contributes to coagulopathy, right? Many of these liver-dependent coagulation factors 2, 7, 9, 10, protein C and protein S that the liver makes, in cirrhosis, we will make those in abnormal amounts. And so we'll usually see an elevated INR. So normal platelets, normal INR, again, decrease the probability of cirrhosis here, but then we have to contend with that against these imaging findings that include ascites, this mass, and this lumpy, bumpy liver, which I will pass the mic to Sharmiz to take us through those findings here.
Wow, what a CT finding. And Jack, that was fabulous. So I 100% agree with Jack as well, right? So clinically, we're not, we have evidence of portal hypertension. We don't have the stigmata of like cirrhosis that we usually see for it. But however, atypical presentation of typical things are still more common. So I think we should hold a place that this is perhaps some degree of cirrhosis, yet also holding the possibility that maybe something else is going on. So the question becomes for me when I'm looking at this CT is all the things related to each other, or are we dealing with two things, right? this might be someone that, yes, because of his alcohol use disorder over time is developing cirrhosis and has another pathology in his belly. So I'm thinking about that. We have a loculated cystic mass that is quite big, that is extending to the pelvis. So the question becomes like, okay, what is this mass? And is the ascites related to this mass? Or again, it's not. So in terms of like, as Jack beautifully mentioned, again, with like, if, with the varices, there is some portal hypertension going on. So thinking of whether they're cirrhotic or non-cirrhotic, then we think about like usually our post-hepatic causes, which tends to be either vascular, like, blood Chiari, IVC, or cardiac, like a constructive pericarditis, your heart failure, not this patient, not that we know of. Intrahepatic, from alcoholic hepatitis to, schistosomiasis, which tends to be the most common cause of ascites in worldwide, to like infiltrative etiologies, and the prehepatic being like usually the portal vein thrombosis that we think about. So again, the question to me is like, how much of it this is maybe cirrhosis, portal hypertension related? How much of it might be related to this mass that we're seeing in the abdomen? What this mass could be, whether it's a malignant or is it an infectious etiology? So I think what will help us make the most diagnostic progress is getting a sample of the fluid. And depending on like whether we can sample this mass or not, I would hold off on that and probably get the fluid first to help dictate the next step. So that's what I would do. And was there colitis or no?
No
Anyway,
colitis, just
no
some
colitis.
background cholelithiasis.
Okay, perfect. All right, Kevin, I am very intrigued. What a case. Yeah, tell us some more.
So I'm first going to give you a description of the paracentesis. They were able to take out 400 cc's of extremely thick gelatinous fluid from the left lower quadrant loculated collection. And then 40 cc's of similar fluid was aspirated from the right lower quadrant free peritoneal collection. There was extreme acellularity in the cytology report, so no conclusive interpretation could be drawn. And then I have some fluid studies. So the color was described as slightly xanthochromic. It was cloudy. There was 400 white blood cells and 1,000 red blood cells. Lymphocytes were normal, only 64 mononuclear cells. And then some additional studies, the albumin was 2, and then amylase, glucose, and lipase were normal. They also checked some tumor markers at this point, and CA 19.9 was elevated at 54, with normal being 35, and a CEA was elevated at 24.4, with normal being less than 5.
Wow. That very interesting. So so the associations that I have honestly with kind of like this gelatinous ascites, the only thing that it's very rare is like a time, I think it's like PMP is a very rare, I actually can't remember what it stands for, forgive me, but I think it's like a very, it's actually a benign, if I believe so, and is a tumor that can cause this kind of gelatinous ascites at times. So that's kind of the only associations that I have with, I'm so curious to learn more. It's kind of like a very rare type of cancer that is actually, I think, comes from the appendix, but I'm not 100% sure. So that is like the thing that jumps out to me, and like the association that I have. Other than that, like honestly, my differential for that is very, very limited. Jack, what are you thinking?
Oh gosh, I am honestly, I am stumped, and I think being stumped at this point reflects the reality that anytime there is a mass or a cystic lesion or something like this, it sort of ends up relying on some sort of formal tissue diagnosis. I feel like I have learned characteristic heuristics of like this infection looks this way, this cancer looks this way. And those may play out over hundreds or thousands of cases, but I have seen cystic lesions that everyone says is infection turn out to be malignancy. I've seen mass-like lesions that everyone says is a cancer turn out to be an infection. And so where I'm feeling really struck right now is grappling with how there can often be such an overlap here, as you mentioned, Charmaine, but then also saying, well, what are the things that we can actually hang our hat on? Can we hang our hat on the CA19-9? And I've learned that in reality, those markers, CA19-9 and the CEA levels, are helpful for monitoring cancer once it's been diagnosed, not for diagnosing cancer when we don't quite know yet. So for example, I took care of a patient previously who came in with a large pancreatic cyst, which was leading to biliary obstruction. And they had a CA19-9 level that was off the charts high. Everyone was like, this has to be cancer. And it ended up being pancreatic or chronic pancreatitis from alcohol use disorder. And so I share that story to drive home the point that the high CA19-9 here and the high CEA level, in the absence of a tissue diagnosis of malignancy, are hard to know what to do with, because many things that happen within the abdominal space or in the peritoneal space can elevate those levels. But if we know that there's cancer there, they become helpful for monitoring. So I'm trying to push those out of my head so I don't anchor to those. And then the question becomes, well, do we have risk factors for cancer here? Do we have risk factors for cancer here? And the answer to that is certainly yes. This is a nearly 80-year-old gentleman, age being a primary risk factor, but also individuals who have underlying alcohol use disorder can be at risk for pancreatic cancers, biliary tract cancers, and then certainly the common cancers that we may see in the abdomen, like colon cancer, also come into play. Are there risk factors for infection? 100%. This is somebody who it sounds like has previously lived or has recently lived in Guatemala, and in individuals who have resided in Central or South America, we may see some risk of particular infections, whether that's going to be common things that can cause cystic lesions in the abdomen, like any sort of pyogenic bacterial abscess, but also things that may characteristically cause cystic lesions within the hepatobiliary system or within the intestines, things like echinococcus and echinococcal cysts like that. And I will say that I will not pretend to know which of those is going to be more likely here. I think based off of the base rate of disease, somebody who has weeks of symptoms, the base rate would say that maybe this is a slow growing intra-abdominal abscess. But I will say like a sigmoid colonic wall bacterial abscess is not something that I've seen very often, whereas things like parasitic infections is something that I have seen. So the features here may favor a possible parasitic the features here may favor a possible parasitic infection over a classic pyogenic bacterial infection based off of the epidemiology as well as the time course here. But these is just all me conjecturing, because I think the reality is that it's so hard to tell based off of the imaging findings alone. And what we really need is ultimately a tissue diagnosis, whether that comes from the fluid or the mass itself. And we have risk factors for both the infections that you mentioned, as well as the potential cancers that we may see. And so I feel like if I'm being authentic, I can't take it much further than that beyond just swirling through the vortex of possibilities rather than necessarily knowing which one it most likely is.
Jack, that was such a beautiful reasoning. I love that, because like you don't necessarily need to know to make diagnostic progress. So again, like I think that was beautifully done. So thinking about infection, thinking about malignancies, I personally got stuck on the gelatinous part, and I'm like, oh, this is unique. So I did type 1 thinking, and then what Jack really did well was like type 2 thinking. So it was like taking a step back and being like, okay, what can I make of the information I have? And that was really beautiful. Just to correct my own self, thank you so much, Mohammed. PMP stands for pseudomyxoma peritonei. Thank you for reminding me. And I think I might have said it's benign. It's not benign. It's actually malignant. So sorry about that. Just wanted to make sure people get the right info out there. Kevin, go ahead.
Yeah, just a couple comments, Jack. I love your reasoning and your train of thought with the information you have. I think also tying it back to base rate is fantastic. And then your points on the tumor markers is spot on. And I think that's super relevant. And then Charmaine, I wanted to comment on, you brought up a point earlier, whether or not the cirrhotic morphology and the cystic lesion were associated or not. I think that's a great example of like Occam's razor, Hickham's dictum there. And now you kind of wanted to anchor on that unique finding of the mucinous ascites or mucinous fluid, and now you're trying to tie it back, still considering like maybe something's going on in the liver too. So I think in interest of time, I'm going to try to condense it to the end here, and we do have tissue for you guys. So a colonoscopy was done and it was normal. We did a transjugular liver biopsy, and the pathology revealed portal and periportal fibrosis, not concerning for cirrhosis. The patient underwent peritoneal biopsy and had removal of 4.5 liters of mucinous ascites. Pathology revealed extravasated acellular mucin, but had no evidence for malignancy. And then while this case is progressing, obviously this is happening over a period of time, the medical student on the team was able to track down some outside records, particularly about the patient's appendectomy 2 years ago. And the pathology from that showed low-grade appendiceal mucinous neoplasm with acute perforated appendicitis, and the margins were noted to be cleared. So next aliquot will give you the final diagnosis.
All right. Well, I will say, just to briefly reflect on this, because I know that we are running short on time here. We now have, I think the liver pathology is particularly helpful because it builds on the point that Charmaine absolutely brilliantly nailed at the beginning, which is how do we link the findings in the abdomen with the findings of portal hypertension, right? A mass in the peritoneum can cause ascites via non-portal hypertensive mechanisms, but we had features of portal hypertension. Now, what we're dealing with is we know that there is evidence of liver fibrosis and what seems like abnormal cells. If I'm just going to abstract that simply, we're dealing with abnormal cells here. And we also have this sort of large cystic lesion in the liver. Just give me 1 second here. I'm going to fix something on the whiteboard here really fast. All right, so we have those two findings. And so then the question becomes, well, what types of things can make their way from the peritoneal space into the liver? And unfortunately, the two things that can do that are infections and underlying malignancies, right? We see that there's fibrosis in the liver, but it's not compatible with classically cirrhotic fibrosis. So I think we have to contend with, is this more likely to be a malignancy or is this more likely to be an infection? Usually, if infection has made its way from the intestinal space into the hepatic space, we will either see direct evidence of that infection or traces that infection may leave behind. For example, intra-abdominal tuberculosis can certainly cause mass-forming lesions. We might expect to see liver granulomas if it has made its way to the liver as well. So I think the absence of clear infection or the absence of the evidence of infection on the liver biopsy decreases the probability of infection, right? We don't see parasites, we don't see acid-fast bacilli, and we don't see granulomas. Well, then the question becomes, can malignancies do this? And we don't see malignant cells, but we see potential traces of malignancy on here, which is this abnormal fibrosis and what seems like this mucin. So then the question becomes, well, can we link mucin to cancer? And the answer to that is yes. There is a variant of adenocarcinoma called mucinous adenocarcinoma, which can arise in the lung in some ways, but you can also see it from intra-abdominal. For example, ovarian cancers can do it, but also cancers of the intestinal epithelium as well. And so I think given the fact that we have this history of appendicitis when the gentleman was old. And when you see appendicitis in an elderly person, I always want you to ask, is there an underlying cancer that could be linking this there? And in this case, it sounds like they didn't really see it, but it doesn't mean that there wasn't potential cancer brewing already. And so I think what these findings help us do is they help us, again, decrease the probability of infection and really center the gravity on mucin-producing cancers. And we know that those can be compatible with cancers that arise from the intestinal epithelium. And the appendix is classically a place where we can overlook malignancies if they were there. And those malignancies can eventually grow over time from a benign or benign type lesion into something malignant. So the fact that we have something in the lower right sigmoid quadrant, a low-grade appendiceal mucinous neoplasm, right? So that is something that has malignant potential. Thank you for clarifying that, Kevin. And so I think this information overall helps us coalesce our findings on saying there was a low-grade neoplasm there that has potentially transformed into something higher grade and more aggressive, made its way to the liver, causing fibrosis in the liver and portal hypertension. And then the mass itself is also contributing to the ascites burden, because if we go back and calculate our SAG, we see that it looks like it's not only portal hypertension that's driving the ascites here. That SAG, I think, is 1.0, which puts us in the non-portal hypertension category. So that would be the way that we could link it all together. As mucinous neoplasm of the appendix became cancer, metastasized to the liver, and caused both portal hypertension as well as this significant mucinous gelatinous material that probably is a byproduct of the actual cancer itself. Charmaine, I see that you're back from doing patient care. Would love to hear if you have any final thoughts to add here.
Nada. That was beautiful, Jack. Kevin, I'm so ready to learn from you.
You guys are spot on. This case is still evolving. It's a very recent case, and the team's thinking was much like your reasoning, Jack, and Charmaine actually mentioned it a little bit earlier, but our presumed final diagnosis is pseudomyxoma peritonitis secondary to this appendiceal adenocarcinoma or mucinous adenocarcinoma.
This was such a fantastic case, Kevin. Thank you so much for presenting it. And it was such a great case for diagnostic reasoning to, what I love about it is like, it starts with like the common complaints that we see all the time, right? Ascites, abdominal pain. And, I feel like the journey of diagnostic reasoning, it's my favorite, especially if it goes through a lot of typical things that we see, and then in something that I personally have never seen. But like the journey there is like where the rich learning and the thinking is. So I really, really appreciate going through this practice and learning from you. Thanks, Kevin.
I will echo Charmaine's gratitude, and I will also say that this is maybe my favorite thing to take home from this is the learning point on what gelatinous ascites could mean. Charmise, you taught me that just now in the last 10 minutes. That was something where I will be honest with the group, when I encounter something that I don't know, I assume that it doesn't mean something, because that makes it far easier for me to make it through the case. And so to walk away from this now with an understanding of what gelatinous like fluid in the peritoneal space could mean, and how that carries some diagnostic utility is just so fascinating. And I'm so grateful to have gotten to learn that. And again, thank you, Kevin, for bringing this not only incredibly rich case, but also the way that you laid it out, I think made for a really, really fun discussion. So thank you. Thank you so much for doing that. And Charmise, as always, it's a blast to get to discuss with you. And thank you so much for being here today, despite the busy clinical duties. Well, with that, we will turn it over to Ala for the teaching points to take us home for the day. Thank you so much.
Thank you for the awesome case. Learned a lot. Going for the teaching points. When we think about distention, we should think about the phases of matter. Is it solids like masses or constipation, liquids like ascites, or gases from, for example, IBD or IBS? Going for the abdominal pain, when we think about it, we should think about time course and location, and never forget the neighboring organs, whether it's the thorax or genitourinary. Don't forget the never misdiagnosis, the VMR and the ectopic pregnancy. V stands for vascular, I for any itis, inflammation, B for perforation, like small bowel or large bowel perforations, and obstruction. When we think about abdominal pain and diabetes, when we think of gastroparesis, and also that diabetes increases the risk of microvascular disease with previous history of surgical intervention. Don't forget that there may be complications like adhesion. Ascites finding positive fluid, ascites findings on examination is positive fluid wave, but we need to confirm it with imaging like bedside ultrasound. When we think about ascites, we should think, is it portal hypertension related or not? We can measure the SAG for that answer. Cirrhosis stigmata, there are 3 stigmatas, major stigmatas like portal hypertension that causes ascites, hyperestrogenism that causes palmar erythema and the gynecomastia, and the coagulopathy with the evidence of easy bruising on the patient. Also, we thought about the chronic alcohol use in this patient. We may think about alcohol-related liver disease and pancreatitis. In this patient, we didn't find the thrombocytopenia, and normal INR makes us think less of cirrhosis. So when we think about cirrhosis, we should think is it intra or extra hepatic, whether it's pre or post hepatic. When we find a mass or a cystic lesion on imaging, we may think is it cancer or infection. The risk of cancer is age in this patient is age and alcohol, and infection. We may think about infection according to the epidemiology and increase the risk with diabetes. What things makes their way from the peritoneum to the liver? Malignancy and infection is the same. If we think about infection, we should expect to see evidence of infection on biopsy, like granulomas with TB. And when we think about malignancy, which is more like in this case, we find abnormal fibrosis and mucin that could be from mucinous adenocarcinoma that arise from ovary, lung, but also from the intestinal epithelium, like in this case. So the framework of this case, the patient had a low-grade neoplasm that transformed to a worse grade that sent to metastasis to the liver and caused portal hypertension. That's it. Thank you so much.
Thank you so much, Alla. Absolutely phenomenal and brilliant summary. I know that many people are seeing it in the chat, but in case you're tuning in on YouTube to watch it after the fact, I'm going to make a plug for the Alert and Oriented podcast at alertandorientedpodcast.com, where you can learn more from the final diagnosis, in this case from Kevin, as well as many other incredible teaching pearls along the way. Thank you all again for joining us today. We hope you have a great rest of the day and look forward to seeing you tomorrow.